and good morning, everybody. As Dr. Galvez mentioned, my name is Luis Rivera, and I serve as a regional toxicologist for the Agency of Toxic Substances and Disease Registry, an agency that's part of the Department of Health and Human Services that works to protect people from harmful environmental exposures. For folks' awareness, Region 2 serves New York, New Jersey, Puerto Rico, USVI, as well as our tribal nations in the north. I also wanted to note that our work on addressing per and polyfluoroalkyl substances, we'll talk about more PFAS exposures in the nation, really wouldn't be possible without the efforts of our sister agency, Centers for Disease Control, CDC, National Center for Environmental Health, NCH, and our state and tribal local partners, especially our New York State Department of Health colleagues who also work hard in addressing exposures to PFAS in your community. Next slide, please. So just a little bit of briefing, ATSDR and CDC have been working really to address the concerns with PFAS exposures for approximately 20 years. Now, nevertheless, we're still faced with many questions about PFAS exposure. So as we address these concerns, our focus is really to investigate exposures to PFAS, and throughout other work, really examine all other potential health effects associated with them. Also to address community health concerns, take action on the basis of scientific information, and provide information to communities and healthcare providers as we're doing today, so you may be able to take care and action and help your community members. Next slide, please. So briefly, ATSDR has conducted multiple investigations, public health assessments, has supported other site work with partners in more than 40 communities across the country, some of which you can see in this map shown here. Specifically, Region 2, as noted on that outbox on the right corner, we have a note of two symbols. We have the triangle and the little diamond shape, meaning that in the city of Newburgh, there are not only an exposure assessment ongoing, but also a multi-site health study, which we'll talk a bit more on the next slide. So briefly to go over the PFAS, ATSDR PFAS research activities, there's so many projects on their way. So with that in mind, I wanted to make sure that healthcare providers just knew a little bit about these activities. Mainly, you may be able to get some folks that have participated in some of the other studies that have pertaining to PFAS in the area. So first, in the bottom left of the triangle, you'll see ATSDR's exposure assessment, which is the focus of today's talk. And these are being conducted in 10 different sites across the nation in communities near current or former military bases that were known to have had PFAS in their drinking water specifically. Primary goal of these exposure assessments is really to provide information to communities about the levels of exposures in their bodies, as well as possibly informing future studies evaluating the impacts in human health. To the bottom right, we'll see that there's the P study, which is really the first site that had the multi-site health study assigned. It was located in Portsmouth, New Hampshire. And that was the first look at the human health effects of PFAS exposure through drinking contaminated water. Those efforts really expanded. And as you see on the top part of the triangle, Congress provided additional funding for ATSDR to fund specifically 7 partner groups across the nation to conduct these multi-site health studies and expand the science on how the drinking water really can harm human health. Now, specifically in New York, which is the area of concern for your, area of capture for you, researchers at the University at Albany, SUNY, specifically PI, Dr. Aaron Bell, and the New York State Department of Health co-investigators, also Dr. Elizabeth Lewis-Michael, they received funding from ATSDR as well to study PFAS and its possible relationship to human health, and among those exposed in the city of Newburgh, as well as in the village of Hoosick Falls and Hoosick area. Just so we'll follow up with today's presentation and participants and include a little bit of information about the New York's MSS work after the webinar. Next slide, please. And the next one, and then we'll do it. Yep, sorry about the animation. So focusing on the exposure assessment, as I mentioned, the Congress had authorized the CDC and ATSDR to conduct these exposure assessments, mostly known as EAs, near no less than 8 current or former domestic military installations that have had or had documented exposure to PFAS in drinking water. So a total of 10 are being studied, and the distribution of PFAS in serum concentrations, as well as environmental levels in the indoor dust and drinking water from those selected households will be examined. The EAs, a quick note, the EAs are not health or epidemiological studies, and ATSDR will not analyze or evaluate health endpoints or biomarkers of disease as a part of this EA work in the city of Newburgh. Do take into account that the city of Newburgh will be participating on the MSS, which will explore a lot of these endpoints in depth. So next slide, please. So just wanted to note that there are limitations of what we can learn from PFAS blood test in an individual. So I wanted to really go over quickly and highlight those. Seen on the left box, you can see that we can learn about what the levels of PFAS in blood are, what the range of those PFAS levels that we can expect in the community, how the PFAS levels in a community compare to national levels, as well as other reference populations, and also what environmental factors might affect those PFAS levels. On the other side, what we cannot learn, and that is if the PFAS levels in someone's blood or urine will make them sick, if there's a health condition was caused by PFAS, how or where someone was exposed to PFAS exactly, and when or how long the PFAS exposure lasted exactly. So there are a few caveats we can recreate with exposure histories, but exactly, we can't really pinpoint it. Next slide, please. So now to go really in a bit of background about PFAS in Orange County, specifically in the city of Newburgh, is that the use and subsequent spills of aqueous film forming foam, that's the AFFF, also known as AFFF, which contains PFAS, occurred at the Stewart Air National Guard Base and during these firefighting trainings and also emergency responses in that area. So PFAS chemicals then travel into the surface water. Back in 2013, PFAS levels from the water samples taken at the city's primary drinking water source, which is Washington Lake, were higher than the Environmental Protection Agency's, the EPA's current health advisory level, which Dr. Galvez will talk a bit more about later, but lower than the provisional health advisory at the time. So the EPA then lowered their health advisory in May 2016, but prior to that, the city of Newburgh removed Washington Lake from service and began really using its backup water supply, which is Browns Pond, a very proactive move by the city, I will say. In June 2016, the drinking water system was connected then to the New York City Catskill Aqueduct system, which also supplies most of the water for New York City. And the service for the city was really under was meeting all the current federal and state PFAS guidelines at the time. Also from early in November or late in November 2016 to the end of 2017, New York State Department of Health conducted biomonitoring in residents of Newburgh and communicated the results to study participants and also addressed some of the physicians in the areas and provided additional education, which is of importance to note if there was some individuals who may not participate from the EA, but may approach you with information that was relevant back in 2016's New York State DOH sampling. Next slide, please, Nora. So this slide, I really wanted just to capture the area that's identified, that's being served by the city public's drinking water system that's shaded out in green. And that's the area that, back in the day when was above the state and federal guidelines was sort of the concern area mostly. There were pockets in the town of Newburgh and the town of New Windsor, but those were not part of the EA site as they were not under the public drinking water systems. And random selection of households were then selected and invited to participate for the exposure assessment. And as I mentioned, on the 2 towns nearby, there are not enough households with private wells in the city to do a scientific exposure assessment. And the same does for the area that surrounds the city. So next slide, please. Sorry, excuse me. So in Orange County PFAS exposure assessment, so all the selected households were eligible in the sampling frame if the household members at that time met the following criteria, and that's if they lived in the city of Newburgh at least 1 year prior to May 2nd of 2016. That's when the water was switched, and thus the PFAS exposure came to a halt. Also, if members are 3 years of age or older and do not have a bleeding disorder and are not anemic. Next slide, please. So now I'd like to briefly walk you through the exposure assessment process. CDC and ATSDR began the exposure assessment back in February 2020 with a public information session in February 11th, and started off recruitment following soon after that public availability session that we had. Then really ATSDR paused all field activities in March due to the COVID-19 pandemic, and quickly resumed them in October 2020. So in late October, ATSDR collected all the biological samples, and currently samples are being analyzed at the moment. That's one of the reasons that means that soon individuals will probably be getting the result as mentioned in the next slide, please. So as some of those next steps, then we'll be mailing out individual results very soon. One of the main reasons for this educational webinar today, intended for physicians in the area. We will also write a final report summarizing the findings and recommendations for your community and present the results in a public meeting with community members and stakeholders. We'll also provide experts in the field to answer questions individually if that is needed. Lastly, one of the last steps will be the National Academy of Science, Engineering, and Medicine. We'll review all the current evidence regarding health effects and develop guidelines that clinicians can then further use. So next slide, sorry. So with that said, I wanted to finalize by encouraging you to reach out with questions about PFAS in Orange County, specifically the city of Newburgh, which is part of the exposure assessment, to the PEHSU or the NICE Check network, or myself if a patient comes to you with questions about PFAS. With that final thought, I don't want to keep you from learning more about PFAS, so I'd like to introduce Dr. Maida Galvez to continue educating you guys in PFAS. Thank you, Dr. Galvez.
Thank you, Dr. Rivera. So I'm going to be walking you through PFAS, what clinicians need to know, and just note my disclosures below. So today's learning objectives for this seminar is really rooted in risk communication or environmental health messaging. And as environmental pediatricians, what we do is try to break down complicated messages into simple ones. And so we use this framework of 3 key messages. It was actually a medical student who shared with us a really easy way to remember this. It's what, so what, now what. And what means defining the problem, what are perfluorinated chemicals, why do we care about them, the so what, and now what. So always leaving families with action items they can take to prevent and reduce exposures, whether it's individual behavior change or reduction of exposures on a larger level, meaning at the community or society level. So in order to answer those questions, we're going to give you some information on PFAS, what's known currently about adverse health effects related to those exposures, both from animal research as well as human studies. And then how you can begin to address some of the commonly asked questions in clinical settings, as well as what's being done on a regional and national level to address some of the larger questions that are remaining. And so this is not an uncommon scenario that communities are facing across the country. So a mother and a 12-year-old son are in good health. The family has lived in a PFAS study area for the past 12 years. The mother had heard that water in their community was contaminated with PFAS, and the family participated in ATSDR's exposure assessment and brings you their individual biomonitoring results. And for clinicians that haven't been trained in environmental health, it can be very challenging to digest. And that's why I want to make sure that clinicians in these impacted communities had information readily at their hands to share. And so here's an example of what a results letter could look like. And so what you see is the different types of PFAS chemicals in the left-hand column. The reported levels for that individual child would be in the second column. And then what we always try to do with any results is put them in the context of what those exposures are compared to what is known in other communities. And NHANES is always our baseline comparison. NHANES has been monitoring over 265 chemicals in the US population for many years now. And we've been able to sort of establish background levels of exposure, as well as universal exposure in the US population. And so you see the US population geometric mean in the third column, or the average. And then you also see the upper limit in the far right column, meaning the 95th percentile. So you can compare it to the mean and the upper limit. And that helps to always take a level for an individual and put it in the context of how they compare to other populations. You can also compare them potentially to other study populations. So let's jump right in. Formerly called PFCs, PFAS are a family of thousands of chemicals that contain a chain of carbon atoms bonded to fluorine atoms. And have these amazing properties. They're resistant to water, oil, and fire. And that's why they were used so widely in a range of consumer industrial products. So if you can see products that are water repellent, for example, it's highly likely that those products contain PFAS in them. PFOA and PFAS are two of the main species, have been detected in the drinking water of millions of people across the country. And you see in figure 1, the family tree of per and polyfluoroalkyl substances. And that NHANES report that I mentioned earlier, which has been conducting biomonitoring of PFAS in the blood of the general use population going back to 1999, what you can see are the trends in those exposures across the US. So here are exposures from 2000 on the left to 2016. And you see for one of the more common PFAS, PFOS, that there's been a steady decline in exposure to the US population due to the phase out of the use of the chemicals in everyday products. And so it shows you the importance of the phase out of use and how that can have direct implications on reducing human exposures to these chemicals. So where else can it be found? I already mentioned water repellent clothing, non-stick cookware, carpet and clothing treatments, paper and cardboard packaging, food containers and wrapping. People think about popcorn, microwavable popcorn. As Dr. Rivera mentioned, aqueous film forming firefighting foam, or AFFF. And then this results in contamination in waste from manufacturing facilities, firefighting foam runoff, into surrounding groundwater, PFAS containing sludge that's used as a soil amendment, and exposures in occupational settings. The routes of exposures are varied and include ingestion, inhalation, and other. Ingestion can be through the drinking water, through food grown or raised in PFAS contaminated areas, from food containers and wrappers, from cookware off-gassing, from stain protectors, and that's from toddler behaviors if there's direct mouthing of that clothing, for example. It can be passed from mother to child through breast milk and potentially also through cord blood, and can also be breathed in through air and dust. And you can see here that for the variety of perfluorinated compounds, that depending on the chemical of concern, the half-life can vary greatly. And this largely depends on whether the long chain or short chain And it can go from anywhere from about a month to as long as 30 or 35-year half-life period. So PFAS binds to tissue proteins that it can accumulate in the blood at much lower levels in the liver, kidney, and brain. Most PFAS are not metabolized by the body. They're primarily excreted through the urine. And in women, they're also excreted through breast milk and during pregnancy and menstruation. Shorter chain PFAS tend to be eliminated faster than long chain PFAS. And elimination rates appear to be different in males as compared to females. As you saw from the N. Haynes report, PFAS has been detected in the blood of most people tested in the United States. So exposure is widespread because of its widespread use. Some PFAS bioaccumulate in people and have long half-lives. Research suggests that exposure in humans can affect many organ systems, and they've been detected in the drinking water systems across the country at levels that exceeded the EPA health advisory, placing populations at risk for exposure. EPA has established a health advisory for PFOA and PFAS to provide communities with information on the health risks of these chemicals. And the EPA health advisory in drinking water is currently 70 parts per trillion, individually or combined. And some states, including New York, have released their own advisories, which are often much lower. And New York State has one of the lowest to ensure high quality drinking water across the state. And so New York State is currently at 10 parts per trillion. And that's because 70 parts per trillion already includes safety factors. And so 10 parts per trillion includes even greater safety factors than 70 does. So we're really glad New York State has done that. EPA's health advisory is non-regulatory, but provides a threshold for consideration so states can then implement their own guidelines. So what are the health effects? The risk of adverse health effects from exposure to PFAS depends on the potential toxicity of the chemical of concern, how they accumulate in the body or the body burden, the dose that one is exposed to, the frequency, route, and duration of exposure, the phase of life. So we think about exposures through the lifespan, meaning in the reproductive years, in pregnancy, in early infancy, childhood, adolescence, and into adult life. And genetic and epigenetic variations in individuals can also factor in. As I mentioned, PFAS can reach children through the placental barrier and through breast milk. And as many of the pediatricians who are in the audience know, children are more vulnerable because they have an immature blood-brain barrier. They have immature vital organs. They ingest more toxicants pound per pound of body weight. They spend more time on the floor where they can be exposed to dust, and those hand-to-mouth behaviors then lead to ingestion. And they're more likely to put objects in their mouth, which are age-appropriate and potentially developmentally appropriate behaviors. So as a result, PFAS and PFOA are commonly found and can be detected in breast milk and cord blood. The background levels have been steadily declining over the last decade. And depending on the specific PFAS, breast milk concentrations can range from 3 to 10% of maternal serum concentrations. What we know now is that the benefits of breastfeeding currently outweigh any potential risk posed by PFAS exposure through breastfeeding. So that's a concrete message you can share with families that you see. I'm going to briefly touch on animal research findings. So animal studies have demonstrated increased risk of adverse health effects, but effects occurred at exposure levels that are much higher than most people experience. Those health effects were enlargement and changes in the function of the liver, changes in hormone levels, suppression of immunity, and adverse developmental and reproductive outcomes. And why this is helpful, animal research is critical to toxicology, and why this is helpful is it helps us to identify the potential organ systems that are affected, It allows us to identify the range of exposures and the impacts that they may have. And it allows us to evaluate controlled exposures without other exposures. Animal studies are different from human studies, as you all know, because the half-lives may be different in animals. There are metabolic differences across species from human to animal studies. Oftentimes those animal studies lack genetic diversity, so these gene-environment interactions are less able to be studied, and the doses are typically higher compared to the human experience. Now, what's known from the human studies? Just a quick time check, we're at 8:31, we're doing okay. The C8 health study is the largest epidemiologic study to date. Included almost 70,000 people ages 18 years and older, and found a probable link between exposure to PFOA and increased cholesterol, ulcerative colitis, thyroid effects, increased risk of high blood pressure, increased risk of preeclampsia in pregnant women, and increased risk of kidney cancer and testicular cancer. And just note, probable link here means given the available scientific evidence, it's more likely than not that a connection exists between PFOA exposure and these conditions. Epidemiologic studies have identified significant correlations between serum PFOA and PFAS concentrations and total cholesterol, specifically in residents of communities with high levels of PFOA in drinking water, as well as in workers exposed to PFAS in occupational settings. The National Toxicology Program conducted a systematic review of the human, animal, and in vitro data, examining immunotoxic effects of PFOA and PFAS. And NTP concluded that both PFOA and PFAS are presumed to be immune hazards to humans. And what they mean by that is a decreased antibody response to vaccines, and evidence of impairment of infectious disease resistance, however, is weak. IARC, or the International Agency for Research on Cancer, classified PFOA under group 2B, that is possibly carcinogenic to humans. And evidence suggests that this carcinogenic potential exists for both PFAS and PFOA in humans. Workers exposed to PFAS and residents living near PFOA production facilities have both experienced increases in testicular and kidney cancer specifically. So here's a summary table outlining some of those health conditions that we've discussed and some of the findings. For example, elevated liver function enzymes, AST, ALT, GGT, for example, reduced kidney function, increased body fat, and increased risk of cardiometabolic disorders, including obesity, altered thyroid function, and learning and behavioral issues, as well as lower fertility and reproductive health. The strengths of the human studies is that they represent real world exposures and scenarios. And that's why human studies, especially prospective cohort longitudinal studies, are critical to our understanding of PFAS and their health effects. And the human studies support many of the toxic endpoints that have already been observed in animal studies. The limitations are that exposure to multiple PFAS that are correlated presents challenges to interpretation. And the prospective studies are more expensive, take longer to conduct, but are stronger than cross-sectional studies. So many studies to date have been correlations or associations rather than prospective studies, which are a stronger study type. Complexity of differences between individuals regarding other PFAS exposures and vulnerability factors is important to address and challenging to do. So understanding the evidence base. No single animal or human study can establish causality. Overall, the evidence base for PFAS effects on health is still in its early stages, and many of the newer PFAS have very limited study. Currently, the ATSDR PFAS clinician guidance reports, which are available on their website, suggest no causal relationship has been established for those health effects from epidemiologic studies. And that's because they're making that distinction between associations or correlations and causal relationships. As the research evolves and grows, observe consistency among studies, dose-response relationships, and identification of susceptibility cofactors will enhance our understanding of the health implications of exposures in the human population. And so what does this mean for your patients? So we'll go back to that scenario, the mother and the 12-year-old son that's lived in the PFAS study area for the past 12 years. They're concerned that the water in their community was contaminated, and they participated in ATSDR's exposure assessment. And they come to you with their individual biomonitoring results. They get their results, they report their levels in comparison to the US population from NHANES, and comparing it to the reported geometric mean, as well as the 95th percentile or upper limit. And what you can do is discuss the patient's concerns and perform a thorough health and exposure history, a physical exam, and then conduct any appropriate laboratory evaluations as indicated by your history and physical, as you would in any patient. I think what's really challenging for clinicians when they get these reports is the ability to interpret the results. Does this family need further testing? If so, for what? And how else can you help this patient? And I think the biggest challenge that we see when families and clinicians call us is that the main health effect and the primary health effect in the acute period is the toxic stress that they have when they learn about these exposures that they did not know about, and how they incurred for many years. And I think it's important to acknowledge that and how scary that is for families. And then it's critical to give families guidance on what that means, how it compares to other communities, and what families can do about it. So what actions can they take as a family to prevent and reduce their own exposures, and what can be done on a societal level to reduce these exposures, not only locally and regionally, but nationally. And so it's important. We think it's really important to acknowledge for families that toxic stress is an acute health outcome related to these exposures, and managing that stress is an important part of the management and treatment of these exposures. And families can often leave very frustrated because we don't yet have great answers for what this means in terms of human health impacts. So they often feel frustrated, judged, and concerned, and feel like their concerns have not been heard. Some tips for engaging with patients is engaging them proactively. If you're a physician that lives in the community that has a family, expressing your own concerns and how you're addressing them can be very helpful to those families as well. And I know that this is something that many clinicians are very good at. It's just expressing empathy for the patient's concerns and being clear and honest about what we know and what we don't know. And then going to existing clinical screening guidance from AAP's Bright Futures, Guide for Preventive Clinical Services for pediatrics, and the parallel guidance for adults. I know we have some adult clinicians joining us today as well. For asymptomatic individuals exposed to PFAS, there is insufficient evidence to support deviations from established standards of care. For patients with signs or symptoms of disease, you really use the established standards of care regardless of PFAS exposure currently. That means following the National Heart, Lung, and Blood Institute guidelines for pediatric cholesterol screening regardless of PFAS exposure, until we know more. And studies are underway examining exactly which exposure levels are associated with increased risk of elevated cholesterol. There is no change to the current immunization schedule for children exposed to PFAS, given the known and clear benefits to immunization. The same guidance applies for those who are treating and managing pregnant women. So monitor blood pressure as you would during a routine pregnancy. There's no need for additional measurements at this time, given the scientific evidence. The benefits of breastfeeding currently outweigh those of not breastfeeding, given what we know about the extensive benefits from breastfeeding. Women who choose to breastfeed should continue to do so even if exposed to PFAS. If the PFAS concentration detected in a patient's drinking water is above the EPA health advisory of 70, and here in New York State, it's 10 parts per trillion, or if a patient is concerned, here are the action steps that they can do. They can install a filtration system, and the filtration systems for individual use that are effective in filtering PFAS are available on the NSF website, or using a pitcher type filter, and those filtration systems tend to be granulated activated charcoal or reverse osmosis. Longer term solutions are alternative water sources if the water supply is impacted, or use of filtration at the water supply level, as well as using alternative sources for drinking, food preparation, cooking, brushing teeth, or any other activity that might result in ingestion of water. Again, this is for those communities that continue to have water, PFAS in drinking water that is above New York State's current level of 10 parts per trillion. Additionally, patients should check for local fish advisory, because if PFAS is present in drinking water, it can then contaminate local seafood. And those fish then that are consumed can expose humans. So do check for local fish advisories and read consumer product labels and avoid using those with PFAS. While most people in the US have measurable amounts of PFAS in their blood, there's no established PFAS blood level at which a health risk is expected or can be predicted. Serum PFAS measurements are most helpful when they are part of a carefully designed research study. A patient's PFAS blood concentration can be compared to the US population as part of NHANES and those from other studies in PFAS affected communities. And this is really important for families in those communities, just to be able to say, these are your levels. These are your levels compared to other communities where PFAS has been detected. And these are your levels compared to the US population. If you decide to move forward with testing with your patient despite these limitations, there are serum PFAS levels tests that are commercially available. It's unclear whether insurance pays for it, which can be a concern for families. So it's important that families understand that what those levels can do is put them into context, but it doesn't change your clinical guidance. So your clinical guidance is really focused on preventing and reducing exposures. That is the most important treatment. Because we are not yet at the point where we know that specific levels in the blood are associated with specific health conditions. There is a National Academy of Sciences committee that's been convened to specifically look at questions about testing and utility of questions, and they're meeting on a regular basis, and they in fact have a meeting, a public town hall this afternoon from 2 to 6 p.m. So key takeaways, most people in the US have some PFAS in their bodies. When patients express concerns about PFAS exposure, be prepared to talk about exposure history, health effects, and blood testing. Reducing exposure to PFAS is the most important first step for families with concerns. Really, you want to stick with established standards of care for patients, even those with an elevated PFAS serum concentration. So screening for health conditions based on existing risk factors. When talking to patients, it's important to address their concerns and acknowledge the stress and the impacts on their family from these exposures, given that there is much that we still don't know, and the challenges to addressing this in the water supply, and how difficult it can be for families to be reassured that their water supply is in fact safe when they've been told in the past that their water was not safe to drink. And that's an ongoing challenge. And one is an environmental pediatrician that we're very concerned about, because there's nothing better to drink than water. And so it's really important that we ensure that there is safe, high quality drinking water for all families, not only across New York State, but in this country. And that's why it's really critical that we protect our water supply and ensure the phase out and reduction of the use of these chemicals to ensure high quality drinking water for all. It's also important to promote standard age-appropriate preventive care services for all families. Ensure that families with these concerns have access to care and access to clinicians who can give them guidance and point them to evidence-based resources. And our team at Mount Sinai, through the Region 2 PEHSU and the New York State Children's Environmental Health Centers, has developed a prescription for prevention. And what it is it's a short communication tool that has key guidance. It basically boils down messaging into key messages on the front of the prescription for prevention. And on the back, it points families to reliable resources for additional information. And those prescriptions for prevention are available on our Nice Check website and our Region 2 PEHSU website, and we're happy to share those with you. Those prescriptions for prevention are also available on a range of healthy homes concerns, as well as green cleaning and safe disinfecting for COVID. And what they're meant to do is to give clinicians the key counseling messages so that they can readily address environmental concerns in the clinical setting and point families to needed interventions. And so a major aim of our work is to help families' environmental concerns get addressed in routine pediatric clinical settings. There's a long list of resources available at the end of this presentation, and this presentation will be posted and will be shared in a PDF form. And I do want to share this evaluation, and we're eager to hear your comments about this presentation and ways that it can be improved. And with that, I will leave this up. If folks are not familiar with QR codes, if you have an iPhone, if you open up your camera, the camera will detect this QR code, open up this link, and that link can be used to answer a very brief survey about this webinar and get your comments. And if you have an Android phone, you do need a QR code reader in order to open up that link. The alternative is to go directly to the link that you see, is.gd/PFAS in drinking water. And we really do value your feedback and comments, and we hope that this has been helpful to you in, and especially if this is your first time hearing about PFAS in drinking water, in understanding the what, the so what, and the now what, in terms of what can be done to prevent and reduce exposures to these chemicals for families across New York State, and particularly in the city of Newburgh. I'll just flash through the resources, and you'll see a range of resources from the National PEHSU Network, or Pediatric Environmental Health Specialty Unit, from CDC ATSDR, from NHANES, from EPA, and I'm going to point you to the New York State Department of Health website, which is truly excellent on PFAS. And then references for all of the slides.